Thanks, Finn. So today's topic is continuous cloud-based early warning score surveillance to improve the safety and overall outcomes of acutely ill hospitalized patients. Regards this talk, I have no disclosures, no conflicts. I actually want to tell the story of where this actually came from. And where this came from was January 1st, actually, 2014, more than a decade ago. Baylor College of Medicine became a part owner of this hospital, St. Luke's Episcopal Hospital, along with Catholic Health Initiatives. And that joint venture, out of that joint venture came the first clinical initiative, which is to create a critical care service. This was a big burly hospital, a huge cardiovascular service line, but it had open ICUs. And here is data on how those ICUs performed up through the first 3 quarters of 2014. And you can see that our performance in terms of the metric for ICUs, which is mortality index, was declining over those years. And really, at the end of 2013, 2014, we were at the bottom of what's called the University Health Care Consortium database. So we were ranked 110, 113 out of 129 hospitals for our ICU mortality index. We had great nurses, we had great doctors, but we weren't getting the job done. So the joint venture board said, okay, we need to create a critical care service. And they found a sucker to lead that service who is standing before you at this time. So now, standing up a critical care service, what do we do? Well, the model was, let's do what typical academic medical centers do, which was develop a cohorted geographic ICU model. You know, this is a medical center level. So neuro ICUs, medicine ICUs, abdominal surgery ICUs, et cetera. Dyad leadership, you know, RNs would be trained and specialized for those units. Intensivists would be recruited and specialized for those units. And then we would do all the usual things that you know from your training, multidisciplinary rounds, starting a pharmacist. One thing that came out of actually the stand-up of critical care was, believe it or not, Tiger Text. So, you know, we all function on Tiger Text now. But the data was that our ICU docs were talking to 6 consultants a day on their patients, and the communication was a real issue. And that's actually how we got Tiger Text into St. Luke's to facilitate critical care communication with all the consultants. Now, at that time, part of the vision, by the way, was to develop a cohort of critical care cardiologists. A couple of years before 2014, this article came out, this white paper came out in circulation, which basically suggested that we need to do a different thing with cardiac ICU medicine than we had been doing for basically 50 years. You know, CCUs came about in the 1960s when we learned that MIs created mortalities, at least immediately, by ventricular tachycardia. And so we developed these CCUs. We put patients around a nursing station. We put leads on them. We saw them go into VTAC and we shocked them. But that old vision of CCU was no longer applicable. And our cardiac intensive care units had a whole new cohort of patients, mostly starring cardiac failure patients, required different critical care skills. So there was a white paper from the American Heart Association suggesting that we actually develop programs for training to develop cardiac ICU specialists, which we've really gradually done over the years. And, you know, our 2 star intensivists in the CCU, as you know, is Dr. Merchant and Dr. Sanuzzi. Okay, so around that time, so in the mid-teens, there was this zeitgeist in critical care medicine. This is a headline article by a guy named Jean-Louis Vincent, who was and is still really the preeminent intensivist in Europe. He's French, and this was an editorial on where we're going in critical care. And the focus of this editorial was intensive care beyond the fixed walls of the ICU. And really what he was advocating, and a lot of this came out of the experience with sepsis, was we should be delivering critical care where patients become critically ill. And in his context specifically, we should be getting to critically ill patients in the ED, getting to critically ill patients on the floor or in the operating room when they become critically ill. So this was a big thing in critical care about this time that we were standing up our ICUs. Okay, so when I took on the job of standing up critical care, I looked, well, where do these critically ill patients come from into our ICUs at St. Luke's? And here's what I found. About 52% of the patients actually came from the ED, which is extremely high. That was one of the highest in the country at that time. From the OR, cath lab, procedural areas, about 25%. And then from the floor, about 20%. Patients who decompensated on the floor, and that's a very, very high number, that floor number. I'll show you some data which tells you what it looks like in other institutions. And then, of course, we got transfers from the outside institutions, hospitals we supported in an evolving common spirit system. And then we looked at this phenomena that we tagged zigzags. We looked at our rapid response data, and we found that about 25% of those patients who came down to us from the floor had actually been admitted from the emergency room within 24 hours. This is actually a poster at the Society of Rapid Response Systems. Who knew, right? So let me diverge just a little bit and talk about the critically ill in the emergency room. So this was another white paper from Critical Care Society, Emergency Physician Society groups, and it addressed the problem of critically ill patients in the emergency department. And I'll draw your attention to this quote. The most sophisticated intensive care often becomes unnecessarily expensive terminal care when the pre-ICU system fails, meaning critically ill patients in the ED is a real problem for our healthcare system. And this is a study that really highlights exactly what that problem is. And this is a big multi-center study. The senior author, which is a guy named Phil Dellinger, who was Baylor faculty a long time ago, is now in New Jersey. Project Impact. So basically what this showed was for every hour a critically ill patient is in the ED, their mortality goes up 6%. Now, there's also a similar problem when patients decompensate on the floor. For every hour, this is another study, for every hour a patient decompensates on the floor and is waiting for a critical care bed, their mortality goes up 1.5%. And these patients who I called zigzag, they come into the ED, they go up to the floor, and then within 24 hours they get transferred down to the ICU. Their mortality index relative to patients with the same set of diseases, conditions, age, et cetera, well, that's 1.44. So let's get back to the stand-up here in critical care. So when we looked at our data here, our time from ED to ICU was about 8 hours. So when we started back in 2014, our time when a patient decompensated on the floor and was trying to get an ICU bed, 4 hours. And we looked at this zigzag phenomena, which is very prominent in our hospitals. So patients go up from the ED and something happens, they're in the ICU within 24 hours. Their mortality odds ratio was 2.5. So some targets. Okay, so let's come off that a little bit. I'll come back to it. Let's talk about rapid response. So this whole area of rapid response, which the fellows and residents have really grown up in, but it was new to guys like me. This actually came from initial observations, pardon me, in the 1990s that showed that 50 to 85% of patients who had an unexpected cardiac arrest in hospitals had deranged vital signs, signals that something bad was happening, signals of significant physiologic decompensation up to 24 hours before they arrested. And then after those set of observations came observations that when that was pointed out to providers, to physicians who were in charge of these patients on the floor, at least 50% of the time they didn't do anything about it. and it resulted in a cardiac arrest. So a lot of opportunity. And that really prompted the development of what we call rapid response. And here is, I'm sorry about this. Here is the article that made that happen in 2003. It was by a guy named Ronaldo Bellomo at the University of Melbourne. And he said, way back then, now 20 years ago, he said, we spend $1 trillion, this is 20 years ago, $1 trillion a year providing for ACLS, training, courses, teams, internationally, $1 trillion a year. When, look at this data from the 1990s, which says that a whole lot of these cardiac arrests, unexpected on floors in hospitals can be prevented. That's what we should really be focusing on. So he developed what he called the medical emergency team. This consisted of a critical care doc, a critical care nurse, and a critical care fellow, again, at the University of Melbourne Hospital. And he put signs up on all the acute care floors, and he said, call this team if the vital signs are deranged, standard things, respiratory rate, heart rate, blood pressure, O2 sat, or if you're worried. So over the course of a year, this simple intervention resulted in a 2/3 reduction of cardiac arrest in that hospital, and this whole concept of rapid response systems was born. And within 5 years, the Institute for Healthcare, Institute of Medicine, multiple credentialing agencies for hospitals recommended rapid response systems. And these systems, if you read about them, look at them, or have experience with them, they're described as having an afferent and efferent limb. The afferent is what's the input, what triggers these intervention teams. That's called the efferent limb. And, these descriptions of these teams can get very complicated, but they can be very simple or very complex, these systems. Now, let me show you this. This is called the National Early Warning Score. So with the birth of rapid response system and this focus of afferent, efferent, people were really looking to develop clinical triggers for these rapid response systems that would reliably detect decompensating patients that you could prevent a cardiac arrest in, or that you can intervene in and prevent acute renal failure or some other major organ failure or mortality risk. And out of all this came this thing called the National Early Warning Score, which is a physiologic-based scoring system. And this is just a collection of a lot of articles around the early 2000s, 2010s, which basically looked at a whole bunch of different physiologic scoring system. And the winner was the National Early Warning Score system. And so that began to be applied in hospitals throughout the world. And actually in Great Britain, it actually became a law that in Great Britain, your hospital, if you had a hospitalized patient, they had to be monitored by the National Early Warning Score. And the way that really looked was nurses twice a day would take a paper checklist on the ward patients, and they do the National Early Warning Score. And again, that proliferated throughout the world in hospitals. But the other thing that happened in looking at this National Early Warning Score system was that it looked like it was a very accurate predictor of mortality for patients who came into emergency rooms. Again, it's a physiologic-based score. So that sort of sets the stage for the talk, which is cloud-based physiologic monitoring and triggering. So a company in Houston stood up probably about 15 years ago now called Decisio. Decisio was actually the first FDA-approved cloud-based decision support tool for hospitals. And let me show you what this thing looks like. This is a Decisio dashboard, and Decisio was created by a guy named John Holcomb. So John was at University of Texas, but John is actually a world-renowned trauma surgeon and trauma intensivist. He spent most of his professional career in the U.S. Army and led their trauma team for the entire military, actually. And John tells a fantastic story about, well, where did he get the idea for this? And I'll go into this in just a minute. But he actually worked for something called Joint Command, which is based in El Paso. So Joint Command is that organization in the military that tracks bad guys, terrorists, and is involved in eliminating those threats. So John was a surgeon attached to this, and at Joint Command, this is many years ago now, they developed a digital dashboard to show where all the bad guys were. And when that happened, the elimination or threat rate, the efficacy of eliminating those threats went up exponentially. And so John had this idea. And the idea was that in ICUs, in critical care, docs like me, your standard critical care doctors, processing 1,500 to 2,500 pieces of data on each patient each day. And in addition, talking to a bunch of consultants. And that data processing, results in a lot of errors. That's been shown over and over in the critical care literature. So John's concept was that we need to cull all this data and show it in presentable form so that critical care docs could quickly assess and take actions to essentially prevent problems or deal with problems early. So he created this company called Decisio, which can take inputs from any electronic health record. Again, this was sort of at the dawn of the electronic health record, or at least the dawn of it being mandated. And he created these dashboards to put in ICUs to make critical care doctors better. And so this is what an individual dashboard looks like. And this is what a unit dashboard looks like. And you'll see that up in 7 South 1 and 7 South 2. So as we were coming on to build our critical care service, we were very attracted to this. And we thought this could really help us to do better in critical care, get those bad outcomes better. And there was or has evolved since the creation of that company a literature around what these dashboards look like. Decisio is not the only company now that does this, but basically in critical care, when you create these dashboards which cull the data and show critical care docs what they need to know, the outcomes improved significantly. The most notable study was from the Mayo Clinic. They had something called Process Aware, and Process Aware was a software application that's predicate to the FDA for approval, was actually Decisio. And you can see what happened at Mayo. When they implemented Process Aware, their mortality dropped very, very dramatically. And again, when Mayo built this system, they actually, it was a long workup to deploying the system. They look at cognitive load. They did a lot of study as to what are important things critical care docs need to know. But this basically showed this concept that culling the data and presenting it in an actionable fashion, that's decision support. That's early decision support, and critical care really has a good outcome. Okay, so let me tie this together just a little bit. So we're standing up critical care about a decade ago at Baylor St. Luke's. Our outcomes are absolutely awful. There's this zeitgeist that says, get to patients early, we have a problem. We have a lot of patients who come from the ED, they stay in the ED long, we know that's bad. Patients stay on the floor long, we know that's bad. So this is how we went after it. This is how we went after getting those outcomes better, which is to go after patients who develop critical illness early, try to catch them early. So the first thing we did was we stood up a mobile ICU team, and this was about 2015. And then in 17, 18, we deployed this cloud-based monitoring system, which I'm going to take into details. We've done other things since then, but I'll leave that be for right now. I can take questions on that. So when we deployed this mobile ICU team, so what's a mobile ICU team? Here it's an intensivist, a fellow, and an APC, a nurse practitioner, usually in critical care. And that team, when we deployed it in 2015, it could respond to the ED. In fact, we asked the ED, anytime you have a critically ill patient, you call us and we'll come see them. So it would go to the ED and it would essentially take over the care of critically ill patients. That team would also, when there was a decomp on the floor, patient needed to go to the ICU, call that mobile ICU team. We would go up to the ICU and we take over the care of that patient, and our nursing support was actually the rapid response nurses. we expanded that team, the rapid response nurses, so that we could do that. And essentially, the result of this mobile ICU was that our hospital-wide cardiac arrest went from 2.2 per 1,000 patient days to 0.8 per 1,000 patient days with this system. This is graphics of what happened here. Before we deployed this team, we were having about 40 codes a month at Baylor St. Luke's. And when we deployed this team, it dropped dramatically. Now it's actually, I just looked at the data, we have about 15 codes a month here. And this is more granular data as to where those code drops were and why those code drops were. And what we found was codes dropped on the floor, codes dropped in the ED, codes dropped in the ICU, and the main reason was PEA arrest drop, right? So cardiac arrest, rhythm, or PEA, and this mobile ICU would typically respond to physiologic decompensation. Typically, they were called by the rapid response nurses, sometimes by providers, sometimes directly by nurses on the floor. But the typical trigger was physiologic decompensation. They would respond to the floor, the ED, and the response was a tremendous drop in PEA arrest. We actually won a pretty big award for this 2018 CHEST. Okay, so then what happened after we deployed that mobile ICU? And this is where we got to the continuous cloud-based monitoring of patients on the floor and actually in the ED. So what Decisio did for us was it continually took physiologic parameters and created a continual national early warning score for us. And actually, along with that, we required all the floors in the hospital to take vital signs every 4 hours. Believe it or not, there was no standard for how often vital signs would be taken. Some floors 12 hours, some floors 4 hours. So we made all the floors, we collaborated with nursing, made all the floors do Q4 hour vital signs, and Decisio took that data that got entered to the EHR and developed continual national early warning scores for us. So on the floors, when the national early warning score hit a certain number, in our case 7, which is sort of the international standard, or if a patient came into the ED and got a national early warning score of 5 or greater, there was triggered on the floor, the rapid response team. The rapid response team got Tiger notified that there was a physiologic decompensation on the floor, and in the ED, when Decisio notified the nurse supervisor in the ED that there was a patient who came in with a high physiologic score consistent with decompensation, there was a whole pathway activated. Patients were fast-tracked back into a room. They actually empirically had the sepsis assessment and protocol initiated, an ED physician fast-tracked to see them. So that's what we did to utilize the national early warning score and our cloud-based monitoring to get to patients early in critical illness, either on the floor or in the ED. And so I'll show you a bunch of data on the results here, but essentially, a lot of good things happened with this model. Our codes went down dramatically. I think I pointed it out, but specifically our rapid response team codes went down very dramatically. Our transfers to the ICU went down dramatically. This is an early paper we published as well. The most critically ill patients on the floor, their mortality actually went down with this system almost 50%. This is a complex model that shows how we did this in the ED, but essentially patients would come in, they would get a Decisio score if it was high, they got fast track, but even if they were in the ED in a room waiting on a floor bed, for example, and they decompensated, the news would alert the ED team, and they would again get reassessed and get the immediate attention of the ED doc as well as the ED nurse. So this system that we put in the ED, we did a year-over-year study. We published this in the British Medical Journal Quality, and it actually was shown to improve mortality for the entire hospital by 12%. So catching these patients early in the ED made a massive difference in overall hospital mortality. This is a graphic of that. You can see down here, graphically, the mortality improved pretty tremendously with this intervention. Now, this is recent data from last year. I presented this at Society of Critical Care, and this is really, really interesting data. Our rapid response system on the floor is triggered by either the National Early Warning Score through the CISIO alerts, Tiger text to the rapid response nursing team, or on the floor, anybody can call the rapid response nursing team. And we actually broke down, well, what did the outcomes look like for these two activation pathways? And here's the data on what that looks like, which is really, really interesting. So group one, which is the patients that rapid response saw because they were news alerted, versus group two, the patients rapid response saw because of a call from a floor provider, almost always a nurse. Well, look at the data here. The ICU transfers were much less when the news system alerted rapid response. The mortality was significantly less for both the patients who went to the ICU and the patients who did not go to the ICU. And look at the cardiac arrests. I mean, the cardiac arrests were basically a third when the rapid response team was notified by the National Early Warning Score. Curiously, in the National Early Warning Score Alert Group, the hospital length of stay, the ICU length of stay was longer. But the overall impact of this, and the message here is that this system, when it caught patients, this National Early Warning Score cloud-based monitoring, when it caught patients early, they had a much, much better outcome than through the older system where the nurses typically on the floor would just call the rapid response system. So that system of getting to patients early in the ED, that system of getting to patients early on the floor, very, very effective, tremendous outcome improvement in those things. And this is actually data. Remember, the story started out with how terrible our ICU outcomes were. And this actually is data that came out just last week. So this is where we're at now, and this is actually where we've looked over the last several years, over the last 5 or so years in the ICU. So I'll draw your attention to our ICU mortality index now. Which is 0.6. And it's been looking like that for about 5 years. So that's actually nationally leading mortality index for ICUs. And I will also point out to you, just so that you can take personal pride in this, look at the 6 South 1 and 6 South 2 mortality indexes. They're tremendous. They're actually among our best performing units, 0.3, 0.4 improvement there, by the way. Now, let me morph a little bit into artificial intelligence, right? So this system we deployed is decisions, we call it decision support, using technology for the decision support of identifying critically ill patients early in the ED on the floor. And I haven't shown you our data as to how this impacts our ICU, but that's the concept as well. Now, this whole area of artificial intelligence has come into this realm here of identifying patients early who are critical, and really the tool in that spectrum of artificial intelligence is machine learning. So, machine learning in a simplified form is, when we think we have a good idea, we form a hypothesis and we test it. But in machine learning, in an environment like an electronic medical record, you can ask a question like, who goes to the ICU or has a cardiac arrest? And you can ask a machine to identify all the variables, whether you think they're important or not, that correlate with those. So there are now folks, or there have been folks working on this. The most advanced is at the University of Chicago, Dana Edelson. This actually just came out a couple of months ago. And basically what Dana Edelson do is she applied machine learning to hospitalized patients, and she showed that with a physiologic-based monitor, if you add machine learning to that and graphics and conditions, et cetera, you can even do better in terms of identifying patients early. One thing, maybe the last thing I'll point out is the next thing you'll see in hospitals, by the way, are these vital sign, wearable vital sign monitors. I don't know, has anybody had experience with these devices? At any of the hospitals, any of the fellows? So I think I mentioned to you when we started this National Early Warning Score monitoring, cloud-based monitoring, first thing we did was we got vital signs every 4 hours. But for the last 10 to 15 years, technology has evolved to the point where we now have pretty good monitors that are wearable that will get you vital signs. One of the very first was this thing called Sotera, which got your respiratory rate, heart rate, and actually through a very innovative technology could actually get you blood pressure from the thenar artery. But the devices have come down and this thing costs $5,000 a unit. But these wearable devices now are a little bit simpler. They can get your heart rate, respiratory rate. But the data is that that's probably all you need for continuous vital sign monitoring. So when patients come into our hospitals, they come in with their Fitbit or their Apple Watch, and then they come into the hospital and they say, hey, doc, my monitoring of my physiology is better at home than it is in the hospital. But what you're going to see now is this stuff coming out in the hospitals. You come into a hospital, you're going to get one of these wearable vital sign monitors, and those signals are going to get Bluetoothed into the electronic medical record. Then you're going to have things like the Cysio using news or even a machine learned protocol to detect critically ill patients in the ED and on the floor. That's where we're going with this. Now, the data is not there quite yet to say that that should be standard of practice, but it will get there. And we actually, at Baylor, really tried to get into this business to use our data scientists, the signals we get from Decisio to develop a more refined early warning system than we have already with the physiology-based system, but we haven't quite landed that yet, but we're working on that. So I think I'll end there and take any questions.